Physiowebseries Neurological Anatomy Season 1. Let's begin with Series 3. In Series 3, we will start learning about dermatomes. In previous series, we heard about the terms dermatome and myotome. Now let's start to learn about it. So starting with dermatome. Dermatome is a specific area of skin which is innervated by single nerve root. So a single nerve root arising from spinal cord will supply or innervate a particular area of skin. That will be called dermatome. So we will be discussing about upper limb dermatomes in this series. We can appreciate this is the anterior view and this is the posterior view. So in anterior view, we can see C2 dermatome is present over here. Backside it is over here. So let's point out each one of them. This is C3. This part is C3. Over here you can see C3. Below that there is C4. Over here you can see C4. Then comes C5. Bilaterally we can appreciate. Over here also there is C5 descending this way. Then comes C6. This orange part can be appreciated. C6 which is at the lateral side. Posteriorly also the orange part can be appreciated, which is C6. Then comes C7. You can just come down. This way we will be moving now. So here was the C6. Now the central part is C7. Bilaterally we can see, and anteriorly and posteriorly also. Then the medial side there is C8. Anteriorly, posteriorly, the pink colored one we can see. And then we are moving this way. We descended this way. C2, C3, C4, C5. And now we are coming over here. C6, C7 and C8 this way. So we are moving up again. So here upper part again the T1 is starting. And again up we have T2. Over here we can appreciate this is T2. T1 was here. And then we are moving up. So this is T2 anteriorly and posteriorly. Then we can see T3 below it, T4 below that. So here also there is T2, T3, T4. Same way going down we can find T5, T6, T7 and so on. Over here it is marked up till T7. In detail, this was C6, C7, C8 and then again over here there was T1 and subsequently T2 and then again the torso part or the thoracic region we have continuation from T3 and so on till T12, which we will be discussing in this series. We have discussed till T1, T2 at least. So in detail if we have to see, forearm region and the palm or hand is covered with which dermatomes. So C6 is over here. The lateral part forms the C6 which is at the side of thumb. Anteriorly as well as posteriorly we can appreciate. C7 after that occupies the central part. Anteriorly is only present in the palm. Posteriorly we can see it is extending to the forearm. Then C8 lies medially at the little finger side. The pink one can be appreciated anteriorly and posteriorly. So this is exclusively about C6, C7, C8. Laterally, centrally and medially it lies, to remember. Now one by one let's focus. You can refer this part in Maggie book. So now let's discuss it. Which nerve root is forming what dermatome? Or which nerve root is innervating which part of the skin, which ultimately forms dermatome, as we can see here. So starting with C1, as told over here, is innervating vertex of the skull. We actually don't consider C1, but as it is mentioned, and C1 and C2, as can be seen in this diagram, they are overlapping. So they have considered in this way. So C1 is for vertex of skull. We can see in the diagram. We can associate this with the diagram at the right hand side. C2 is now temple, forehead over here, and occiput, the back part. So we can see, and also it is extending this way. So this whole part is C2, anteriorly and posteriorly, both ways. So this upper part till here, extending till here, we can see over here also, that was C2. Now coming to the next, which is C3. Here it can be seen there is entire neck. We have to assume it bilaterally. So there is this entire neck, posterior cheek, temporal area, some part of this temporal area is there, prolongation forward under mandible, this way. So this forms C3 dermatome. It is clear. Then coming to C4, there is this shoulder area, clavicular area can be seen bilaterally, we have to assume. So clavicular area and then upper scapular area. So the posterior part is not shown over here clearly, but the upper scapular area. So this forms C4. Now next will be C5. This and this diagram, both of them. So C5 occupying the deltoid region, we can see here. Anterior aspect of entire arm. The anterior aspect of entire arm, and it is going towards the base of the thumb. Not covering the entire thumb, just the base of the thumb. Because we know base of the thumb is occupied by C6. As we have studied it earlier in detail, C6, C7 and C8, those three dermatomes. So C5 will end at the base of the thumb. Rest of the part will be covered by C6. So C5 will end at the base of the thumb. This we can correlate with this diagram. So this is the anterior part, and posteriorly here the C5 is just extending at some part. We can see that. Now coming to C6, as we have discussed, the forearm and palm part of C6, C7, C8. Let's see it in detail. So anterior arm, C6 is also covering the anterior arm, and then radial side of hand. This is the radial or lateral side of hand to thumb and the index finger. So here they are considering thumb along with the index finger. And this is the posterior part, arm side and thumb along with the index finger. The lateral side basically, to remember. So this was from C1 to C6 dermatomes. Now next is continuing with C7 going till T12. C7, there is again lateral side of arm and forearm also to index, long and ring fingers. So this whole part is C7. Then C8, here the small picture is shown. You had already seen the forearm part. The medial side is covered by C8 dermatome. So medial arm as mentioned over here, but not shown in the diagram. So it is medial arm and forearm along with the little finger, mainly the ring finger. Some part of the long finger may be overlapped. So they have mentioned it here, but we are considering the medial side basically. So mainly is the little finger side or the medial side, and from that the forearm also the medial side and arm also the medial side is covered under C8 dermatome. Next comes torso, the thoracic part, which can be appreciated over here. And in this diagram, it is divided bilaterally, as they have to show one thing, that if this is T2, this is T3. That means some part is overlapping. So in this diagram, they have to show that. Otherwise, we consider those this way. that the dermatomes are lying one by one. We had seen it earlier, how the T1 is somewhere over here, and then upwards we have T2, then T3, then T4, T5, so on till T12. So it divides at the torso this way. We will again see the diagram, but here it is shown bilaterally. We have to assume it as complete and some part of it is overlapping. So we can see where the T1 is at the medial side of forearm to base of little finger. We know that as the C6 finishes, somewhere there only the T1 begins. We were going this way like this, and then here only the T2, T3, everything will continue this way, and then so on. There will be lower limb dermatomes also, but here we are focusing on upper limb. So T1 medial side of forearm to base of little finger, only till base, because rest is mainly C8 dermatome. So T1 was this. Then T2 is medial side of arm. We can appreciate over here. It is the medial side of arm to medial elbow. You can just refer to this diagram at the same time. So medial side of arm, medial side of elbow, pectoral and mid-scapular area can be determined over here. So that was about T2. Then T3 to T12. So in that also they had divided T3 to T6. That is somewhere this portion. This forms the upper thorax. So that will be covered with T3 to T6. Then T5 to T7. Again this one is at the costal margin. Then next is T8 to T12. As we can see, it is in the abdomen and somewhat lumbar region. So this is about the torso. T1 is at the medial side of. T1 is also like namely thoracic, but then too it is present mainly at the medial side of forearm. And then T2 will continue from up, and then continuing that way we will reach till T12. So those were the total upper limb dermatomes till T12 we are considering the torso also. So that means we are total seeing about cervical and thoracic region. So here C1 is not mentioned. So we are directly talking from C2. As we can see, C2 and then below that C3, C4, C5, C6, C7 and C8. So if talking about this diagram, if we assume the human body in this particular position as seen in the lateral view or the side view, then this is the most easy way to remember the dermatomes. Over here, as we are considering the upper limb dermatomes, we are considering just cervical and thoracic. The rest of the part will be covered in next series. So now focusing on cervical and thoracic region, as we have already seen till T12 part, which is till over here. So we can see how it is descending from C2 going down C3, C4. So you can just dissect this and understand how they are going and covering up the skin portions. So C2, then going down C3, C4, C5, C6, then this way C7 and taking a turn up. C8 is ending over here, medial side. Then T1 is also at the medial side and it is going up basically. If you can traverse this way, then up here we have T2. It will continue now till T12. T2, T3, T4, T5, that way till T12 over here. So initially while assessing the patient, you can just keep the dermatome chart to correlate, and later on with practice we can become strong enough to identify those dermatomes easily on a patient we want to as a physiotherapist. So next, now let's discuss, let's start about the clinical aspect. Like we said that we can just use the dermatome chart for initial thing, and then we can later on also identify those dermatomes without the chart with practice. So how to check and what to see? So as in previous series also we came to know that there is a disc in the central portion, or there is an intervertebral disc between two vertebra. Posteriorly there is a spinous process of vertebra. So if this, and here somewhere over here there is intervertebral foramen through which the spinal cord is passing, the vertebral foramen through which the spinal cord is passing, and the intervertebral foramen between two vertebra through which the spinal nerves are emerging out from the spinal cord itself. And if this disc in the center, due to some pathology in it, is impinging or is causing pressure, if it is herniating, the pathology which may be herniation of the disc, if it is causing impingement of the nerves which are coming out, then it may appear as symptom on the patient. So we can check for it as a way of altered sensation. Either there is pain, or there is numbness, or any of the altered sensation. So we can just test for it. So while doing this procedure, we can ask the patient to close their eyes, and we can just test for each and every sensory component. So here it will be considered as neurological sensory component, because the nerve which is supplying is the cause, and the actual cause will be the disc or other thing which is causing the impingement of that nerve. Because of that, we are able to see those symptoms. So what all sensory impairments can be seen, we are just going to test that. So as we know the basic things, we can test for light touch, gross touch. So with sharp object we can test for pain. So while testing, we have to consider both the sides. Suppose if you are testing for left forearm, then also go for right forearm, and we can compare the sensations to come to a conclusion. Also, apart from that, we can have pressure sensation, then temperature, and then vibratory sense. So we can just use cotton to test about light touch. So we can ask the patient to close their eyes, and then we can use that soft cotton to touch at the particular part. For example, we took as forearm to test. So we will check bilaterally and see for the impaired sensations. Our goal is to test for impaired sensations. And if we are finding some abnormality, then we will now understand that which dermatome is this particular region. So we will understand where, at which disc level the problem is, or which vertebral level the problem is coming from, basically. So this was about it. Now going into detail of the clinical aspect, we came to know how to test. And now suppose we have now seen about the dermatomes, which skin portion is supplied by which single nerve root. We have seen that already, and also we saw how to test for those altered impaired sensations. So in this example, we can see, in previous series also we saw that there are spinal nerve or nerve roots arising from the spinal cord, and at which level which nerve root is present. We discussed about that. So over here we can see this is C8 nerve root, which has some problem, which is impinged. So suppose now, as in this diagram, there is this central disc, there is this in the center the nucleus pulposus. We had studied this in earlier series. So in center the nucleus pulposus is there, and surrounding is the annulus fibrosus. Now if there is herniation of the disc posteriorly this way, and if the annulus fibrosus ruptures in some case, so this will entirely come out and will impinge over here, or it comes laterally this way, posterolaterally this way, it can cause impingement of this nerve root, or the nerve which is coming this way at any side, this or this side. So the main cause was this disc herniating, which is the disc pathology, which is responsible to cause this C8 nerve root to impinge. As we can see, this is the C7 vertebra, and below C7 vertebra we know that C8 nerve root emerges or exits below the C7 vertebra, and in this case it is impinged. So that means the problem in disc is somewhere. Which disc is that? It is somewhere between C7 and T1 vertebra. The disc is either herniated or bulged or protruded, and causing pressure or impinging the C8 nerve root because it is located over there. So naturally that nerve root will get trapped between that. And since we know here, like we are knowing that C8 nerve root is impinged. As a case, if we take this, that C8 nerve root is impinged. But as a physiotherapist, when we will check for dermatome, if the pathology has descended so far that it is causing some symptoms to pain, and the patient is coming to us, to a physiotherapist, and they check about the dermatome because the symptoms presenting are something like pain, numbness, etc., altered sensations basically. So we will go proceed by checking dermatomes because of such altered sensory components. So we'll check the sensory component. Now here the C8 nerve root is impinged. Now if we consider this part, the forearm and the hand, anterior posterior view, which we had seen in detail previously also. So this is C6. So if I check these sensations over here, this portion, it will be fine. If I check it at C7 also, the skin portion, it will be fine. But when I come to see at this portion, I may find that there is some altered sensation anteriorly and posteriorly. So we are talking about this, that your C8 spinal nerve root is impinged. Hence, abnormality you will find will be somewhere over here only, either anteriorly or posteriorly. We can find or come to a conclusion by seeing that there is some altered sensation in this pink portion because here the C8 spinal nerve is coming out of spinal cord and is innervating this portion. And since there is some problem with that nerve which is innervating this portion, hence, we are seeing it as some altered sensation or impaired sensation in this particular portion. So that is the significance to test dermatomes and directly come to a conclusion, which can be this. As we came to know, it can be disc pathology, herniation of disc or something like that. So this is the importance we need to know. Now here if we are going to check C6 dermatome in case of C8 spinal nerve root which is impinged, so you may find that in C6 dermatome everything is fine. In C7 also everything is fine, and in other dermatomes also everything is fine, but the problem is over here. So we come to a conclusion that maybe the C8 spinal nerve root is impinged and the problem is coming from here, which is referred over here because the nerve is supplying in that course. So this needs to be understood as the basic thing in clinical aspect. So here also, as we discussed, the same thing, disc pathology is there. So nerve, which will be the sensory nerve, the sensory component of the nerve, we will be considering as we are discussing about dermatomes. So it is associated with skin. So if the sensory nerve is trapped or impinged, there will be altered sensation or pain to the part it supplies or wherever it innervates. Now, in certain cases, this can be found as cervical radiculopathy if there is some problem in cervical spine. So, in those diagrams, as we can see, the cervical spine is highlighted. Over here, we can see there is herniated disc. The nucleus pulposus, the annulus fibrosus is just ruptured, and the central portion, the nucleus pulposus, and it is all impinging this nerve root which is emerging out. And let's consider that, associate this diagram with this. Here also we can see the trapped nerve over here by the herniated disc. This is the normal one. This is normal one where the disc is properly intact in its space and the nerve has its room to do its work. But here in cervical radiculopathy, we can see again there is a trapped nerve over here. Again there is this C8 spinal nerve root which is trapped, taking into consideration. So we may have cervical radiculopathy where the pain might be referred wherever it supplies. Now here it is only C8 nerve spinal nerve root in this example, but over here considering that there are multiple areas. Now this is the vertebra I am considering as cervical spine. In between there will be disc, So we know that disc pathology might occur at multiple regions, not necessarily only one as shown in this diagram, which is C8, but at multiple levels. So considering we can have that cervical radiculopathy and hence the entire arm, forearm, and here we can see some or the other altered sensations found. Pain, weakness, numbness. Weakness will be another thing which will be noticed more of when myotomes are disturbed or myotomes are involved, which we will be discussing later on. But now considering the dermatome part. So the same thing again in detail we can see here there is thinning of disc or the compressed disc, and as the pressure which comes vertically down, which the vertebral column, the spine has to bear, and it has certain things, ligaments, other structures, soft tissue structures, and the disc itself has the central nucleus pulposus and surrounding annulus fibrosus. There is some reason why it is like that, because the central portion will take up all the compression forces and the annulus fibrosus region will resist the distraction forces or the tensile forces. So the disc has to do all this work. It acts as a shock absorber. But as aging occurs, we know that there will be degeneration of the disc, degenerated disc and osteophytes. There will be narrowing of the space. So the nerves which are there will ultimately face entrapment because of that impingement. And in case like it has become weak, so there may be herniation due to some or the other mechanical force to that part. So the problem arises from here. We can see there is thinning of disc over here, like those are the normal discs shown, again the degenerated one this way, which occurs with aging. Hence we can predict that there must be some problem occurring from here, so it will impinge the nerves and hence affect the dermatomal region, which we can test in a basic manner, which we saw in this series. So that was about the dermatomes. To easily remember, you can just keep in mind this diagram in lateral view when the human body is assumed in this position. We can just divide again if we discuss from C2 only till cervical and thoracic regions. C2 you have to just go down, just traverse this way, then take a turn upwards. There will be C8 and then go up again. You will have T1, go up again, you will have T2 and then go this way, the whole torso. End up at T12 and then from L1 there will be another story starting for lower limb dermatomes, but in this series we are just focusing on upper limb dermatomes. So that was it for this series.